Okay. Okay, continuing off, let's go to the adverse effects of Class 1A antiarrhythmics. So, synchronism, which is headache tinnitus with quinidine. Synchronism with quinidine. There's reversible SLE-like syndrome with procainamide. And that one I know because that, yeah, I don't really know that. And then heart failure seen with disopyramide. Thrombocytopenia, Torsades de Pons due to an increased QT interval. And so, yeah, that's expected. That's also unique in that you don't see Torsades de Pons as an adverse effect in Class 1B or Class 1C because both of those actually only decrease the action potential, right? Class 1A is the only one in which the effective refractory period is actually increased because of the partial potassium blockade. So that contributes to increased QT interval or QT interval prolongation, resulting in Torsades de Pons potentially. We open up Sketchy again, and we can kind of see the little sketch here. So here is we're looking at 1A, and this is the tin cans. Represents the synchronism, which is seen with quinidine. This is the prom queen. She's next to the tins. And we also were told that we get, let's see, heart failure with disopyramide. Right? The prom queen disappears. Talking of the Chris prom queen, she disappeared. And so that's why there's a heart failure balloon with prom queen disappearing. Okay, and then the last one, which was, so there's procainamide, and that's with SLE. I think these two are not related. This is Wolf Parkinson White, Wolf 3 Wolf banner, but then this separate wolf is actually for SLE wolf, I think. Okay. Yeah, so Prom King's Lupus Wolf. That's this. Procainamide can cause Prom King, procainamide, or Prom King. Oh yeah, you can see my. Can you see my? Oh yeah, I can see that. Alright. Just checking if you can see that mouse. So Prom King, Lupus Wolf, procainamide can cause a lupus-like syndrome, raising an ANA titer. So yeah, just remembering this little block will get you so many of those. Then you also got thrombocytopenia, and then the torsades de pons, which is the streamer here. So heart failure is seen with disopyramide. The synchronism is seen with the prom queen, right, which is quinidine, and SLE like symptoms is seen with procainamide. And then Wolff-Parkinson White is actually not on first aid, but let me see if here White Wolf Pack Class A treat Wolff-Parkinson White syndrome. Oh, they treat Wolff-Parkinson White, the type of supraventricular tachycardia involving extra signals in an accessory pathway. Yeah, it's sort of mentioned in first aid. It says that treats both atrial and ventricular arrhythmias, especially reentrant and ectopic SVT and VT. So in brackets, maybe should be Wolff-Parkinson White syndrome, since that's a cause of an accessory pathway resulting in a reentrant tachycardia. Alright, moving to class 1B. That consists of lidocaine and mexiltine, eyed by Liddy's Mexican Tacos. The mechanism is weak NA channel blockade. It's the weakest out of them, following the CAB mnemonic or the CAB mnemonic. It's the weakest. That means it dissociates the fastest, which is why it's best for the acute setting of a post-MI. It binds to the sodium channel in the inactivated state. I wish I had a picture of that, but binds to sodium channel in the inactivated state. And also it's important to keep in mind that excuse me, in a heart that's undergone a myocardial infarction, there's ischemia in the heart, and an ischemic heart results in more depolarized myocytes. And again, as it was said in the top of the page, that these sodium channel blockers selectively depress tissue that is frequently depolarized. That's why this is a good drug for this setting. But it's also it has the least or the weakest binding strength out of these three classes or subclasses of class 1 antiarrhythmics, which is why it dissociates very quickly and has minimal effect. So it's good to give in low doses, and it will wear off quick, because if it doesn't, you get CNS depression or stimulation and cardiovascular depression. So it decreases the active potential duration, so it actually makes the effective refractory period shorter, right? Whereas class 1A makes it longer. Basically makes us more skinny. It preferentially affects ischemic or depolarized Purkinje and ventricular tissue. Phenytoin can also fall into the 1B category. Okay. So, yeah. Anyway, from memory, I'm not looking at the page, so from the sketchy, class 1A treated SVT, which is supraventricular tachycardia and ventricular arrhythmias, and then the middle one, which is B, class 1B, that treated, I think, only ventricular, because it's for post-MI, So clinical use is acute ventricular arrhythmias, especially post-MI, and digitalis induced arrhythmias. IB is best post-MI, and CNS stimulation depression. So anyway, this was unique because it is the only one that increases the QT interval by potassium blockade, and 1B decreases that and makes the active potential skinnier. It decreases the slope the least, and also decreases the QT interval. Moving on to 1C, we got flecainamide, propafenone. Can I have fries, please? Flecainide and propafenone. Their strong sodium channel blockade, which significantly prolongs the effective refractory period. Strong sodium channels, because it's the strongest. The CAB, it was the strongest binding out of all these subclasses. So strong sodium channel blockade makes it the least steep. Significantly prolongs the effective refractory period in the AV node and accessory bypass tracts. There's no effect on the effective refractory period in Purkinje and ventricular tissue. Okay, so this is effective only when it comes to the ERP, effective in the AV node and the accessory bypass tracts. AV node and the accessory bypass tracts, meaning, yeah, so it slows conduction from the atria to the ventricles. That's why also in Sketchy it showed both the full heart was lit up in the sign. Right. So it significantly prolongs the effective refractory period in AV node and accessory bypass tracts. There's no effect on the ERP in Purkinje and ventricular tissue. There's minimal effect on action potential duration, right? So minimal effect on action potential duration, right? Essentially, it just spends less time in depolarized state. That's what it's doing, right? When it up here, it's just spending less time. If you take the gray line, you see there's more time in the depolarized state, which is a positive action potential. It's just less time, but doesn't affect this point or this point. So whereas this one does and this one does, and so that's why it says there's minimal effect on the action potential duration. So it treats SVTs, including atrial fibrillation, and only as a last resort in refractory ventricular tachycardia. Adverse effects include proarrhythmic, especially post-MI. It's contraindicated, right? So 1C is contraindicated in structural and ischemic heart disease. So it's contraindicated post-MI. So if a question asks what's the best drug post-MI, it's probably going to be lidocaine, and if answer choice includes flecainide or propafenone, don't pick those. Yeah. Okay. Also, I have notes in my other book says that going back to class 1B, lidocaine terminates arrhythmias by producing bidirectional block in circuit as opposed to a unidirectional block, which causes it in the first place. Allows the reentrant pathway. So it terminates arrhythmias by producing bidirectional block in the circuit as opposed to a unidirectional block. If it's just a unidirectional block, that's what, if there's a right bundle branch block or a left bundle branch block in the heart, the heart normally will want to depolarize the cells which in which weren't depolarized yet, because it will go back up that right bundle branch block or left bundle branch block area to depolarize the cells that could not reach or could not receive the action potential. And so lidocaine is good because it terminates bidirectionally, so it eliminates that possibility of a reentrant pathway, which is good. Right. That's just a good part of it. Interesting part. Right. So, okay, moving on. Moving on to beta blockers, class 2, antiarrhythmics. There's metoprolol, propranolol, esmolol, atenolol, timolol, and carvedilol. All are olols except for carvedilol. These are all beta blockers. I think, yeah, carvedilol is the only one in this list which is a non-selective beta blocker. And just going to confirm. Yep, alright, so it's a non-selective alpha and beta antagonist. So the only ones, at least according to first aid or in first aid, are carvedilol and labetalol. They're the ones that don't have the olol or olol ending, so ilol and alol. So carvedilol and labetalol are non-selective alpha and beta antagonists. The beta 1 selective antagonists block beta 1 more preferentially than beta 2, although there's still some beta 2 blockade. That's all the olols: acebutalol, which is a partial agonist, atenolol, betaxolol, bisoprolol, esmolol, and metoprolol. And the non-selective beta antagonists, which block beta 1 and beta 2 receptors at an equal rate, are nadolol, pindolol, which is a partial agonist, propranolol, and timolol. So from this list, there's a mixture, right? And the best way to just differentiate and know instantly whether you're talking about beta 1 selective antagonist or a non-selective beta antagonist is if the first letter of the drug of the beta blocker goes from A to M, or A to M, it's a beta 1 selective antagonist, and if it goes from N to Z, it's a beta 2 selective antagonist. But then also remember that carvedilol and labetalol are non-selective alpha and beta antagonists because if they're modified, they have modified suffixes to show that. Nebivolol, that also has an olol, but it's nebivolol. There's interest. It's a unique one because it combines cardiac selective beta 1 adrenergic blockade with stimulation of beta 3 receptors. It stimulates beta 3 receptors, which activate nitric oxide synthase in the vasculature, which results in a decrease in systemic vascular resistance. So nebivolol increases nitric oxide. So nebivolol, the N in nebivolol, and the O and olol should remind you of nitric oxide. So it increases nitric oxide, resulting in decrease in SVR because of its combined beta 1 and beta 1 blockade and beta 3 stimulation. So the mechanism of action of beta blockers is that it decreases the SA and AV nodal activity by decreasing CAMP and decreasing calcium currents. Decreasing CAMP and decreasing calcium currents. It suppresses abnormal pacemakers by a decreased slope of phase 4. So that's in a pacemaker cell occupational graph. That's basically the first line, the flat line. So phase 4. Also, to some extent, prolongs repolarization, which is phase 3. Okay, so this is basically, there's no phase 2, so it's phase 4, 1, up here, 3, and then back to 4. So phase 4, 1, 3, 4. So there's a slight prolongation of phase 3, and there is a decreased slope of phase 4, basically meaning that the whole the SA and AV nodal activity, like the whole action potential is increased, the duration, right? The whole point is to suppress the abnormal pacemakers. It does this by decreasing the SA and AV nodal activity. So the AV node is particularly sensitive, which makes sense. It's the rate, I guess, limiting node. It determines to more extent the heart rate. So rate limiting. So AV node particularly sensitive. It increases the PR interval. And esmolol, I've done this before. Esmolol is very short acting. It's a short acting drug. So it increases the PR interval, and esmolol is very short acting. So the esmolol is very short acting. It decreases the left ventricular contraction velocity and heart rate. So clinical use includes SVT, ventricular rate control for atrial fibrillation and atrial flutter. So in atrial fibrillation or in atrial flutter, there's multiple nodes or foci of action potentials occurring, resulting in the atria going crazy. So those all get sent through the AV node to the ventricles, and that could obviously result in multiple action potentials hitting it, and potentially leading to tachycardia, heart rate, or increased heart rate, and an MI if it goes on for too long. So SVT, ventricular rate control for atrial fibrillation, atrial flutter. So because the beta blockers decrease nodal activity at the SA and AV node, it helps to, I guess, put a blockade or barrier to all these action potentials coming from the atrial fibrillation or atrial flutter in the atria. Okay, so adverse effects of beta blockers include impotence, exacerbation of COPD and asthma, right? Because there is some beta 2 blockade, depending on which beta blocker you're using. There could be some beta 2 blockade, and beta 2 agonists like albuterol increase the airways, so that's good for COPD and asthma. But if you're blocking the beta 2 receptors, then that can exacerbate COPD and asthma. Cardiovascular effects: bradycardia, AV block, heart failure, CNS effects, sedation, and sleep alteration. So cardiovascular, bradycardia, AV block makes sense, right? Because that's literally what it's doing. And heart failure as well makes sense. Bradycardia. CNS effects: sedation, sleep alteration. Sedation, sleep alteration. Maybe because the heart rate decreases, cardiac output is equal to the stroke volume of heart rate. So maybe a cardiac output would be decreased because of the decrease in heart rate. If there's a toxic level of beta blocker in your bloodstream, that can result in decreased oxygen delivery to the brain, resulting in sedation and sleep alteration. May mask the signs of hypoglycemia. Well, I guess in hypoglycemia, low sugar levels. I wonder if it says here. Low sugar levels. I mean, what's the response to you start to get jittery, your heart rate increases. So if you're taking beta blockers and you're also hypoglycemic, you may not realize that you are, because beta blockers would negate that response, that natural response. Metoprolol can cause dyslipidemia. Metoprolol can cause dyslipidemia. Metoprolol. The M in metoprolol, dyslipidemia. The M in dyslipidemia. Metoprolol can cause dyslipidemia. Propranolol can exacerbate vasospasm in vasospastic angina. Propranolol can exacerbate vasospasm in vasospastic angina. Propranolol can exacerbate vasospasm in vasospastic angina. I guess because it's a non-selective. Propranolol is a non-selective beta blocker, right? It's after N, right? A to M is beta 1 selective, and then N to Z is non-selective. So P is propranolol is after, P is after that, after N. So there is some beta. There's beta 1 blockade, but there's also beta 2 blockade, and beta 2 stimulation results in vasodilation. So if you're blocking vasodilation, the problem in vasospasm is that there's increased alpha 1 activity, right, resulting in, kind of periodic, somewhat erratic vasoconstriction of the blood vessels in the heart, in vasospastic angina. So propranolol can exacerbate that because now you're taking away its one response, which is to stimulate beta 2, the heart. So if you're taking that away, you'll exacerbate vasospastic angina. Yeah. Alright. The beta blockers except the non-selective alpha and beta, which is labetalol and carvedilol, except the non-selective alpha and beta antagonists, cause unopposed alpha 1 agonism. Right, of course, if given alone for pheochromocytoma, right, or for cocaine toxicity. Unsubstantiated. Okay. Treat beta blocker overdose with saline, atropine, and glucagon. Okay. Treat beta blocker overdose with saline, atropine, and glucagon. Atropine, why? Because so in beta blocker, beta blockers decrease the heart rate. I guess saline is just to increase the blood volume. Atropine treats, I believe atropine is an anti-muscarinic, right? Let's go double check. So I think it's to treat the bradycardia. Should make this. So let's just see. Anyway, right, exactly here. So muscarinic or cholinergic drugs, right, for M2 in the heart, it decreases the heart rate. So basically, if you're using a beta blocker, you're getting the same effect of as if you were stimulating M2. Instead, you're blocking beta 1, but it's the same effect of decreasing heart rate and contractility. And I guess for beta blockers of the heart, it's the whole heart, atrial ventricle. So this is a cholinergic. So if you give an anticholinergic or anti-muscarinic, which is more specific here, you'll see. So atropine, muscarinic antagonist, used to treat the bradycardia and for ophthalmic complications, right? So there you go. Well, I guess we're not gonna get back. Okay. So yeah. So that's what that's for. And then the glucagon, I would assume, because if you're using beta blocker and you have a non-selective beta blocker like propranolol, you'll also be blocking beta 2, and on the pancreas, alpha 2 or alpha cells produce frick. Yeah, alpha cells produce insulin and let's just double check. Let's see. Yeah, alpha cells. Oh no, that was wrong. They synthesize the glucagon, right? Right. Yeah. So alpha cells produce glucagon, beta cells produce insulin. So I guess if you have beta blockade, you could have beta cell blockade of the pancreas, resulting in a decrease in insulin. Decrease in insulin meaning you have high blood sugar. So why would you give glucagon? Yeah. Or is it because if you are hypoglycemic, this is just a precautionary, or it's if you also do know you're hypoglycemic, it's to, that doesn't really make sense. So glucagon increases heart rate. Glucagon increases heart rate and myocardial contractility and improves atrioventricular conduction. These effects are unchanged by the presence of beta receptor blockade. This suggests glucagon's mechanism of action may bypass the beta adrenergic receptor site. Oh, okay. So in a situation of beta blocker toxicity, giving glucagon allows it to bypass any blockade of those beta cells, so in order to increase heart rate and myocardial contractility. Yeah. Interesting. So I guess we have glucagon receptors on the heart. Let's see. Yeah, stimulation of glucagon receptors associated GS protein stimulation, which causes the downstream. Yeah, I mean, I'm just gonna assume that's a pretty safe assumption. I'll alter it. So. Alright. Just gonna add that. Oh, I was at the wrong page, my bad. Okay. So glucagon increases heart rate, improves atrioventricular conduction. These effects are unchanged with the presence of beta receptor blocking drugs. This suggests that glucagon's mechanism of action may bypass the beta adrenergic receptor site. Alright. Alright, class 3 antiarrhythmics, amiodarone, ibutylide, dofetilide, and sotalol. Monicus beads. Amiodarone, ibutylide, dofetilide, and sotalol. And sotalol and dofetilide bind best in the resting state, known as reverse use dependence. There's more binding in patients with a slow heart rate. Therefore, bradycardia in a patient on sotalol and dofetilide is dangerous because of the increased risk of Torsades de Pons in those drugs. Yeah, because of those drugs. Interesting. So they bind best in the slow state, the slow heart rate, resting state. Okay, so mechanism of action is increased action potential duration, increase effective refractory period, and increased QT interval. Alright, so just like class 1A drugs, there's potassium channel blockage resulting in increased QT interval. Okay, so class 1A and class 3. So increased AP duration, ERP, and QT interval. Clinical use is atrial fibrillation, atrial flutter, ventricular tachycardia, amiodarone and sotalol, AFib, atrial flutter, and ventricular tachycardia. AFib, atrial flutter, and ventricular tachycardia. In rush time. Alright, so it's used for AFib, atrial flutter, and ventricular tachy, mainly because it results in increased QT interval, right? Increase the ERP, resulting in slowing of this heart rate. So sotalol adverse effects include Torsades de Pons, excessive beta blockade, it's also a beta blocker, part beta blocker. Abutolide results in Torsades de Pons. Okay, so the two, let's see, I guess dofetilide also. Anyway, amiodarone can result in pulmonary fibrosis, hepatotoxicity, hypothyroidism, right, or hyperthyroidism. So amiodarone is 40% iodine by weight. So I guess it would result in what? Wolff-Chaikoff. So acts as a hapten, corneal deposits, blue-gray skin deposits, resulting in photodermatitis. Yeah. So axis, amiodarone axis. Hapten. Hapten is something that increases the potency or the immunogenicity of something, either a drug or antigen. So yes, that makes sense. Why it results in corneal deposits, blue-green skin deposits, resulting in photodermatitis, right? Irritation, inflammation of the dermal layer of the skin. There's neurologic effects, constipation, cardiovascular effects, bradycardia, heart block, and heart failure. Makes sense because it's supposed to slow the heart block, all that. So, cardiovascular effects, neurologic effects, and constipation. Remember to check the pulmonary function test, the liver function test, and the thyroid function test when using amiodarone, right? Because amiodarone can result in pulmonary fibrosis, hepatotoxicity, and hypo or hyperthyroidism. So check PFT, LFT, and TFT when using amiodarone. Amiodarone is lipophilic and has class 1, 2, and 3, and 4 effects of these antiarrhythmics. So it accumulates in many tissues. The half-life is around 58 days. It's got a very low washout rate though. Half-life 58 days. Amiodarone is associated with a lower risk of interstitial points. Amiodarone is biliarily excreted in bile, and it's safe in renal disease. So it's secreted through bile. Many potential side effects due to the accumulation in these tissues. Therefore, it's given mostly to older patients and less in young patients. Okay. Amiodarone. It's given to older patients and less in young patients, and accumulates. The reason you get pulmonary fibrosis, hepatotoxicity, and hypo or hyperthyroidism is because it accumulates in all these different tissues. Okay. That's me. Alright. So let's go to the last page. So class 4 antiarrhythmics or calcium channel blockers. This includes, these are the cardioselective ones. There's other ones, but so basically these are the non-dihydropyridines, which are diltiazem and verapamil. The non-dihydropyridines. So the mechanism of action is that they decrease the conduction velocity, increase the ERP and the PR interval, and they inhibit L-type calcium channel. So that's important. T-type calcium channel seen with a blockade is seen with ethosuximide in treatment of absence seizures. So these non-dihydropyridine calcium channel blockers inhibit L-type calcium channels. So clinical use is that they prevent nodal arrhythmias, such as supraventricular tachycardia, and they're used in rate control in atrial fibrillation. Right. They decrease conduction velocity. So diltiazem and verapamil, DV, decrease conduction velocity. Decrease conduction velocity. Decrease conduction velocity. Decreases conduction velocity.